Well, I just wanted to say welcome to everyone. It's hard to believe we're at the April research rounds already at the end of the school year. I just wanted to start today by recognizing the lands that I personally am sitting on, those of the Musqueam people, and now Richmond, British Columbia. I worked on these lands 20, 30 years ago now, and I didn't appreciate or recognize the origins of the land, so I do so retrospectively here today. I'm so grateful. I'm looking out here and I see the full cherry blossoms and the smell of ocean air, and just reminding me of those years ago. I also want to acknowledge that many people here today are situated on the traditional Anishinaabe and Haudenosaunee territories. And just thank each of you for taking the time over the next hour over lunch to be here as we consider how the research at HSPRI can help support principles of equity, diversity, and inclusion. And today, as we listen to Joan Almost talk about how these principles can be applied to healthcare organizations and how we can foster positive work environments. So I'm thrilled that Joan agreed to be with us to present today, Joan Almost. Joan is an associate professor in the School of Nursing, and she's a nurse herself. Her research examines practice environments and work relationships. And we all know the pandemic has taken its toll on many people, but in particular healthcare professions. And Joan's work is instrumental in informing a positive way forward. Joan has been a core to a Queen's team led by Dawn Drummond and Duncan Sinclair looking at issues of health human resources. And so Joan will be presenting her work. You can see her title on the screen here, looking at nursing workforce challenges, thinking about finding new ways to move policy for meaningful change. Joan, I'll stop talking and hand the floor over to you. Thank you.
Thank you, Catherine, and thank you for the introduction and also for the invitation to come and talk about my work here. This is an area that I'm very passionate about. So those of you that have heard me speak before do know that once you get me going, it's hard to stop me talking about some of this stuff. I do have my chat open. So it's certainly if there's questions or if I make a point along the way that's not clear, feel free to mention it in the chat box and I'll clarify as we go. I'm not someone that tends to like to sit and talk about myself for 45 minutes. I like to engage people, but it's a bit more challenging to do that in this type of setting with the virtual presentation. Let's see if I can advance my slides. So just to give an overview of what I'm going to speak about today is first of all, just talk about the nursing workforce challenges, both now and as well as for the past 23 years, because they're very closely linked, minus the pandemic factors. And then also talk about how for the last, I've been an academic now for about 20 years here at Queen's since 2011, and really kind of talk about how I've tried to find ways as my career has advanced about moving policy forward, because that's where I think a lot of what we need to be doing around work environments and some of the challenges within the workforce needs to happen, and how I, as an academic, have tried to find ways to do that, especially now as I'm nearing the end of my career. So first I'm going to start off just by giving a picture for those of you that may not already know all of this is, kind of what the pandemic's done globally. And a lot of this information is based on a report that was put out by the International Council of Nurses with James Buchan from UK leading it. So the country's really had to, for the last 2 years, have had to develop very quickly a surge capacity to meet unpredictable increases and changes in the health services. And we've all lived through that with our own experiences, whether it's personal or in our workplaces. But the nursing workforce particularly their responses have really focused primarily on increasing the overall nurse workforce capacity and shifting to critical areas and other areas where they were needed. So that's been global. I mean, we've certainly known in Canada what's been done. So it's things like requiring nurses to work longer hours, different shift patterns, being redeployed to different clinical areas or even other provinces in some cases, sometimes with additional training, not always. Bringing back non-practicing nurses as temporary or voluntary returners, deploying student nurses to frontline work, and using temporary or agency staff and within Canada, especially Ontario, more recently, the fast tracking of international student or nurses into the workforce instead of having them not be able to work here, though they've been licensed back in their own country. So that's kind of what the pandemic's done from a nursing workforce perspective in general. And there's a growing evidence base that this really has a personal impact, not only on nurses. I'm gonna talk a lot about nursing today, but certainly I'm not minimizing the impact it's had on other healthcare professions. Physicians also have a higher level of burnout. So it's not to say that others have not experienced the same. And I think any workforce right now is going through a lot of changes. But within nursing, especially, the stress, the workload, the risk of infection, the demands made of nurses to basically just cope and be resilient. And now more concerningly is the, about moral injury, moral distress, PTSD, and other implications. And also what effect all of these responses have had on nurses beyond just the workload and other aspects is, what's the consequence of redeployment, new responsibilities that they now have that they're probably not going to give up or be asked to give up because it's become the norm. Lack of access to PPE. We certainly read about that a lot in the media and what has been the implications of that. And last year, the World Health Organization estimated there was about 115,000 healthcare workers globally who died because of COVID. And we certainly know that that's a conservative figure because there's lots of lack of reporting or the data is just not there in some countries. So that's a significant impact on the mental health of healthcare workers. So globally, the nursing shortage, even prior to the pandemic, was estimated by ICN that we would need 5.9 million nurses because we're an aging profession globally. 1 in 6 is expected to retire in the next 10 years, and that was 2 years ago. So now it's within 8 years. So even then, we needed 4.7 million new nurses to be educated and employed just to replace those who are retiring. And now the pre-pandemic shortage of nurses has been, exacerbated by all that's happening. And nurses, as we can see in the media, are leaving, either leaving the employment or going on disability or sick leave, or leaving nursing altogether. So it's become very critical. And the latest through, again, the International Council of Nurses is that we're going to need 13 million nurses by 2030. It's an estimate. It keeps kind of changing. Canada hasn't made a similar bold statement. Now we focus more on shortages in each province as opposed to Canada. But you can see on the slide here, for nursing in Canada, right now we have 10 nurses per 1,000 population, which is not enough. Our population is aging. Our population is going to need more nurses. Not less. And you can see this is an OECD countries, where there's probably about 30 countries or so, we're at the bottom end of the number of nurses that we have. So it's a growing concern globally. So what about Canada? We don't need to look much past the media. They've done a lot to talk about what, nurses are experiencing. And in my 40 years of being a nurse, I've never seen so much coverage of nursing in the media on Twitter. Now, Twitter probably didn't exist 30 years ago, but certainly there's been a lot that have talked about the shortages that are coming. So it's not a big surprise. And on Twitter, again, lots of nurses are very active in posting pictures. The unions are very active in posting. And certainly in Ontario, we've talked a lot about the Doug Ford and the not wanting to give a wage increase beyond what was expected, mandated a few years ago. So certainly a lot has been done about how nurses are not doing well. And this was even from earlier this month in the Toronto Star about, nurses and healthcare professionals need more respect in the work that they're doing. And most of the work is predominantly focused on hospitals, but that's because that's where the most nurses still work. So again, it's not to say that the impact's not affecting other sectors, but unfortunately, hospitals are the main focus of a lot of the media attention and a lot of the union work and a lot of what I'm going to talk about today. And then even this past week or so, there was a post within the Winnipeg Free Press about Manitoba spending up to 40 million in private agency nurses, but I think they're spending $3 million a month on private agency nurses because of the shortage, and posting that, and that's just sort of what they're doing, and they're not trying to find ways to make up the numbers that are missing. So just to give an overview of kind of the numbers of nurses and the different designations in Canada. So you can see on the slide, there are 4 designations of regulated nurses in Canada. We have the licensed practical nurses, which is what they're referred to in everywhere in Canada except Ontario, where we call them registered practical nurses, which they're the same role, the same designation. It's just for some reason our legislation many years ago chose to use the word registered versus licensed because of the history of the practical nurses in Ontario. We have the registered psychiatric nurses, which are often called RPNs in out west. So they are nurses that have a special education program. They get registered as registered psychiatric nurses. They're not registered nurses. They are separate designation. They only practice within the 4 Western provinces. So they stop at Manitoba, and then there's 1 or 2 up in the Yukon. They're not in Eastern Ontario or Eastern Canada at all, but there's been some talk about doing that. And again, the reason for that is it's just a different philosophy of mental health within nursing. Registered nurses, which has always been and still is the largest designation, and then nurse practitioners, which you can see has grown quite a bit. And of the groups, they are the ones that have grown percentage-wise the largest. LPNs have also grown significantly from a number perspective. So you can see every year we go up. 2020 is a bit of a blip because we did have a lot of nurses come out of retirement and come back. So even though the numbers have gone up, it will be interesting to see what 2021 shows, which would be out shortly from a high. So that kind of gives a picture of who the nurses are. And the question often is, well, the numbers go up every year. How can we have a shortage? What's important to remember with these numbers is these are active licenses. The CIHI gets their data from the regulators of active licenses. So you could have a nurse who's on disability, long-term disability, or not being able to go back to the workplace that may still have their license, but not actually working. So it's not a true representation of the context. And then this is a slide I stole from a recent presentation by the Canadian Federation of Nurses Union and the Canadian Nurses Association that looked at, the national shortage. So you can see, starting on the left-hand slide, there's over 100,000 vacancies within healthcare and social assistance, according to Stats Canada. And that number seems to go up every time they report this data. With nurses, that's 33,000 in Canada. So it's in 2 years, it's been over 100% increase in the number of registered nurses and the registered psychiatric nurses, the number of vacancies in each of those positions. And I think even the ones that are filled are empty for about 90 days. CIHI has reported that 1/3 of the RN workforce is over 50, so they're going to retire soon. Maybe sooner than they were expected, though with inflation the way it is, maybe not so soon. And then certainly the levels of burnout. 94% of the nurses who responded to the survey, and I don't have the total number that responded, but 94% experiencing burnout, and 45% of those 45% of the nurses were experiencing severe burnout. So over the next year, most of them have said 1 out of 2 they're going to leave their jobs. 1 out of 5 is going to consider leaving nursing. And they're eligible to retire. So we're in a very concerning state about what we're going to do with the nursing shortage. In nursing in Ontario, you can see, the Ontario Nurses Association, which is our union, reported that we're short 22,000 nurses, and that there's 20% nurse vacancy rate in the hospital. So and every province has similar different numbers that they are reporting as well. So what is being done? So Canadian Nurses Association and the Canadian Medical Association have done 2 types of summits where they've invited multiple organizations, multiple professionals, where they have had a talk and chats, and they talk about what they're doing and support each other. And then they've done 2 news releases based on that. Ivy Bourgeot, who's at the University of Ottawa, who's done a lot around gender research and looking at interprofessional workers, has done, is everywhere in the news. If you follow any type of this work, she's been the one that's being invited to a lot of places to give her feedback, and she's really pushing to get more data because we just don't have the data to support a lot of what we want to do. ICN has released both the policy brief as well as a bigger report about the global pandemic. The Royal Society of Canada has asked a group led by Gail Tomlin Murphy, to do some work around nursing. And this is just a picture of their executive summary. I don't think the full report's out. And then Health Canada has asked the Canadian Academy of Health Sciences, given them some money to do an assessment on health human resources as well. So looking at, some of the literature and then give a report over the next year or so, I believe. And then as Catherine mentioned, I'm doing some work led by both HSPRI and Duncan Sinclair and Donald Drummond, with Joan Trander's also involved, Morgan Slater, as well as St. Lawrence College, looking at what can we do as a research institute, as an academy here, to try to find ways to move forward. And as anyone who's similar to my age or close to it that was nursing back in the early 2000s, this has all been rather a deja vu, because a lot of this was already being done different. We didn't have certainly the pandemic. We had SARS, which wasn't at the same capacity we have now, but it's been a lot of very similar ideas, challenges. 13 years ago, the Canadian Nurses Association predicted that Canada would be short 60,000 nurses by this year. I don't think they have the stats to say whether we are or not, or whether it's more. I haven't certainly seen any stats to actually make a prediction about the shortage nationally. And really what a lot of nurses are saying, especially ones that have been doing this for 20, 25 years, is that, what we're going through is not new. It's been this relentless, intense, and continuing drain of energy, morale, and health, mental health especially, for decades. In the 1990s, we had a lot, was when we started doing a lot of restructuring, a lot of cuts. Healthcare was under attack by governments with a lot of cutting back on budgets, and it's just persisted for years. And this has just opened up the crevice and changed it from a crack to a major gap. And back then, report after report. 1999 is when it started in Ontario. RNAO did some work here in Ontario. Nationally, they started looking at nursing strategies. Wendy Nicklin, who at the time was the chief nurse at Ottawa Hospital, talked about thank you isn't enough. Funding was reported for different policy synthesis on healthy work environments. The Canadian Nursing Advisory Committee, which was led by Judith Shamey and Health Canada, had another major report put out with lots of recommendations. I think they had over 51 recommendations, which some were followed, some weren't. And again, report after report. And then finally it ended with a survey back in 2005 is when it was reported. So it probably went out in 2004. So I think, it's been that, and that didn't show that even with all these initiatives that were in place, we had a national nurse in place, we had many initiatives going forth, that the work environment still wasn't where it should be. And the promise was that this survey would be done every couple of years, which it wasn't, unfortunately. So we haven't had a lot of data that we can consistently say, that changes have been made. But it's trying to move forward with this a little bit. So working conditions, again, looking back even pre-pandemic, we had talked about a lot of overtime. And that a lot of this has been presented by the Canadian Federation of Nurses Union. So it is union based, which it's predominantly their members that are reporting to this. So it is, again, predominantly hospital based. But even back in 2016, we had RNs were working 20.1 million hours of overtime. So that's equivalent to 11,000 full-time jobs. 20% of nurses, worked overtime on a weekly basis. 17% worked paid overtime, 12% unpaid. And, research has shown that overtime is a predictor of nurse turnover. And then absenteeism back in 2016. So 4 years before the pandemic started was already a concern, with 8.7% absent due to illness or disability. And this is higher than the average of all other occupations. So again, millions of work hours, which was equivalent to almost 16,000 of full-time RNs, which was $989 million a year. So it already was a big issue many years ago. This is not new, what we're dealing with now. And that's been the frustration with a lot of people. And then just before the pandemic, again, surveys been done showing just before the pandemic that the mental health of nurses is not where it should be. 1 in 3 screen positive for major depressive disorders. 1 in 4 screen positive for a generalized anxiety disorder or clinical burnout. 1 in 3 had suicidal thoughts. Greater than 20% screen positive for the PTSD and panic disorder. And workload was identified as an area of extreme stress. And then the last survey was around, the work environment. So again, 66% rated the quality of the work environment fair or poor. 80% reported physical violence from patients and their families, and that's another area that's been increasing over the years, with 1 in 5 having verbal abuse daily from patients and families at work, and then 65.3% reported high levels of emotional exhaustion or burnout. So you can see this is all pre-pandemic, so it doesn't paint a pretty picture, and then you can imagine what the pandemic hitting us and the consequences of that. So why are nurses leaving now? It's poor mental health, lack of access to supports, unbearable and unsafe workloads, including workplace violence, chronic understaffing, poor working conditions, dangerous nurse-patient ratios, inability to take a day off, and suspended vacations. I've spoken with nurses that haven't had a day off or a holiday for a year or two. And you think about yourselves. How would you be coping if you didn't have time off when you felt you needed a break? So a lot's been going on, all very concerning. And I think as I've sat with all of this, passionate about this area, in the 2000s, we had a lot of research being done that described a lot of this, the importance of healthy work environments. In Ontario, we had the Ministry of Health have funding available for nursing research. Through the Nursing Research Fund, we had Canadian Health Services Research Foundation, which now has moved their research funding area into CIHR, and they have a separate mandate. They had a separate nursing research fund. We had SHRC was still doing a bit of health research, and so forth. And a lot of that over time is dried up. So now it's mostly focused on CIHR is where any type of this work is done. And practice environments has become out of vogue, is my experience, and that's my opinion. But it's been a challenge to get research to do this. And I think we need research beyond just describing the problems. We need to start looking at how can we make changes. And that's what I've tried to focus on. So Kathy asked, is there any info regarding nurses working as a member of a healthcare team? I'm not quite sure what you mean by that.
It's Kathy. Some of the information that you presented about the nurses' disenchantment with the working conditions that they're working under, but I didn't see any information around as a member of a team of clinicians working together for patient care. Was there any disenchantment around the workforce collectively was what I was looking at.
Okay, thanks for clarifying, Kathy. I think, I think working conditions, some of that is certainly the interprofessional practice. And I think that is part of it in some contexts, but not always. And I think that doesn't seem to be something that's come out a big part. I think what's come out as the big issues is really the workload, lack of PPEs, being expected to not have days off, and that type of thing. I haven't seen a lot about the actual members. Certainly lack of respect has been something I've seen a lot of, and I don't think it's necessarily respect from other healthcare professionals. I think it's respect from government, respect from the organizations and management in some degrees. So, but the teams don't seem to be the main concern. So I'm just going to talk a little bit about my research and again, what I've tried to focus on. And I'm just cognizant of the time, so I don't want to run out of it. I want to make sure we have a chance for discussion at the end. So back in 2010, I led a grant that was funded by the Ministry of Health, so was able to get some funding from the Ministry of Health as part of the Nursing Research Fund that looked at provincial correction settings. So I started looking at, what are some ways? This is a setting that hasn't had a lot of research. And at the time, the chief nurse in Ontario was interested in this context. So we were able to get some funding to look at this. And what we did was we kind of did a study looking at what are the issues, did a survey of the 30 At the time, there's 30 provincial correctional settings in Ontario. And this is provincial, so it's not the federal jails, it's the provincial. Most of the ones here in Kingston are federal. So I think it was, and we also used surveys that we could compare it with other contexts. And the ones that really kind of jumped out at us was the working relationships with correction officers, which obviously you're not going to have a lot of that in other settings, as well as colleagues. High levels of bullying, conflict, especially with the corrections officers. Lack of physical workspace and equipment. If you've ever had a chance to do a tour of a jail, especially provincial jails, a lot of them are over 100 years old. There's not a lot of space, limited access to education. So again, they don't have rooms to go to do education. They're lucky if they have a computer that doesn't have a small screen in the lounge where they have lunch. So all of that was very considered a little different than the context of other settings. And then the big one was around healthcare managers that have high levels of burnout and rollover load. And these numbers, were quite astounding at the time. So one thing that led to, as a result of this, was really Linda Ogilvie was part of this, and she is, I think still is, I don't think she's retired, is the kind of the chief nurse for the correctional facilities in Ontario, is that she was able to take this to build a business case to promote supports for the healthcare managers, because she was even a bit astounded. And a lot of this data also gave her a chance to take that moving forward, of how she could improve the work environment. So she was quite delighted to get this data. And then we did a follow-up study that looked at what were some ways to then focus on the learning needs, because the nurses, because they work short-staffed, nurses tend to stay within corrections. They tend to actually seem to be quite satisfied, but getting nurses into the context, into the work environments was a challenge, because their salaries, they're under a different union, so their salaries are a lot lower. So we looked at ways that we could actually look at doing this. So we decided in consultation with Linda and some of the managers about what we could do. So we developed some online learning. And we did a very participative study where we got feedback from the nurses, what they wanted, what area was the focus. Mental health and addictions at the time was a topic that seemed to be very relevant. So we chose to focus on that. And we did 30 modules over 15 weeks, and I think we used, I can't remember which, we used different platforms. And it was something, you think, nowadays we think online learning, like that's not a big deal, but back then it wasn't something that was done, and the platforms that were available hadn't quite ironed out a lot of the wrinkles. So the nurses weren't too keen on the education, but we learned a lot about the technology side of it, and the number of firewalls it took us to get access to, so the nurses could get watch online learning at work. And even the IT department within the correctional facilities were surprised at the number of firewalls they had to get through, and having nurses not having access to the emails and so forth. And it really helped inform policy. And even though we felt deflated because the nurses didn't like the intervention and so forth, Linda was ecstatic because it gave her so much data about how to inform future education. She'd never thought of having her nurses join each other online, and now uses that all the time across the 30 sites in the province. And also she was so excited when I did a tour there was one jail recently built for about 5 years ago in Toronto, and was so excited when it took me on a tour of it that they now have this big education room with a big large TV. So it was something, again, the study itself didn't show a lot of change over time, but from a policy perspective, the stakeholder, the knowledge user, really found it relevant. And then I did a study looking at leading indicators in occupational health and safety. Again, a lot of things around how do we, find ways to make the environment safer, and beyond doing audits and looking at absenteeism and injuries. Leading indicators looks at proactive ways of doing it. So it's been something that's been studied a lot in other sectors, and certainly healthcare is aware of it, and uses some of it. So it's not that they're not looking at leading indicators, it's just more of a different mindset. So when the Ministry of Labor was funding some research, we were lucky enough to get a grant within this. And what we did was we kind of used the work that had been done in mining. There was an article that had looked at certain sick leading indicators based on the research that they had found, and gave an overview of the kind of questions that we could use. So we kind of developed that for healthcare, had some people go in and do assessments or consultants, and then develop interventions based on that. And again, we did 2 sites here in Ontario, and it was very well received. I mean, it was always challenges with doing organizational research, but it gave them a chance to kind of think of it differently. And then one site, it did show some changes over time. And we had hopes that there would have been a bit more traction with this, but it didn't seem to go anywhere beyond just doing some presentations. But it was something to trying to find different ways of looking at health and safety rather than just using lagging indicators. And then starting in 2018, I started working or volunteering actually as a scholar in residence at CNA. I started my sabbatical in 2018, 2019, and approached Mike Villeneuve, who was the president at the time, our CEO at the time, and did some work with them. And I'm just going to touch a little bit. I still kind of do use the title, but I'm not doing as much work with them as I was previously. But they still call upon me every now and then to help with something. But just some highlights based on policy work is I had the chance to be part of a policy brief that went to the Standing Committee on Health, or referred to as HSPRI, and was able to actually be part of one of the hearings that talked about workplace violence back in 2019, which was an interesting experience, a learning opportunity. And certainly nothing really happened at the time because election was called shortly after, I think a year or so afterwards. And so that's been picked up recently, and there's been a bill passed about adding violence charges, that they're able to charge people within healthcare settings more easily now under the criminal code. So I'm not sure how much of a difference that's going to make, but it has been something that moved forward a little bit. And then also probably one of my biggest pieces was working on a pan-Canadian synthesis. So CNA in 2018 actually opened up their membership to include all regulated nurses. Previously, they were just focused on RNs and nurse practitioners. That's been, they've existed over 100 years, and that's sort of been who their membership has been. But they finally realized, it needed to be all regulated nurses in Canada. And then, part of doing before this, they did a lot of consultation with nurses and found that really nurses don't understand the roles of each other. They don't understand the roles of the professional body, the union versus the regulator. And there's a lot of confusions about scopes of practice and across the different, designations about who should be doing what and what does scope of practice even really mean. So they identified the need that we really needed to have a better understanding of our own picture of who we are. And also, government, if we as nurses don't understand it, people that are knowledge users in the government aren't going to understand it either. So I was asked to write a report, and it's about 200 pages with all the appendices that it took me a couple of years to write, because that was really a thoughtful report, and it was really looking at trying to find ways to write it without having a lot of bias in it. I'm an RN from Ontario. I've been an RN in Ontario my whole career. And for me to write about there's psychiatric nurses out in, out west and licensed practical nurses, who do I consult to get an unbiased opinion? So, and if I bring research into it, is that fair? Because most of the research has been on registered nurses. The research on nurse practitioners has been predominantly in Ontario, because that's where over 4,000 nurse practitioners practice. And because there's less research on licensed practical nurses or the registered practical nurse or registered psychiatric nurses, does that mean that they're not as important? So it was really a lot of, for me, figuring out how I wanted to present this in a thoughtful way. So what the report does is it provides a description of the current landscape of nursing in 2021. And talked about the different groups, what our education is, what our scopes of practice are in general, starting from the legislation down to what actual practice might look like. What's the differentiation between regulated nurses and unregulated health workers, such as the personal support workers or physician assistants. And then what were some general recommendations moving forward, and what's the structure of our organization? So what is the role of the professional association? What is the role of the regulators and the role of unions? So it was very well received. I certainly received a lot of emails about people using it, and I've heard through different people that they've heard about it at presentations or even policy work that they've been doing. So it is something that's been well received. And some of the key takeaways from the report was that basically, it showed within nursing we have our own traditional divisions. There's a lot of overlap between the roles within education as well, and regulation and scopes of practice. So it's like we need to be able to describe ourselves better and understand what we're doing and be able to tell others what the differences are. But all of this really, has led to some intra-professional issues. We've done a lot of research around interprofessional practice and less so about intra-professional. So it's needing to find ways to help us understand each other and remove some of that role conflict that exists in some of the poor relationships. So we can actually then provide higher quality of care. So the next steps were really around, needs to explore different structures and practices to move forward, getting rid of some of the barriers and traditions that we've had for over 100 years and moving forward, and then really trying to find ways to have an intra-professional approach to overcome this. So again, very general description and very general recommendations that CNA wanted to take them forward, that they need to be the ones taking this forward with other nurse leaders. And out of this has come a couple of other opportunities. So I was invited to be one of the members or authors on several papers that were part of a special issue within the Canadian Journal of Nursing Leadership at the end of last year. And I built on this report to talk about ways to start building a more unified nursing voice. We have a lot of voices within nursing. I often hear people say that nursing doesn't have a voice, and I don't agree with that. I think we have a lot of voices, sometimes too many voices. And sometimes some voices are very quiet, that are advocating for nurses very strongly every day, that might not be on Twitter promoting it as much as others, but it doesn't mean that they're any less important. So it was trying to find ways to get the regulators to work with the professional associations, to work with the unions, and move forward as a group. We have over 400,000 nurses. And imagine the power we would have if we all had one unified voice instead of having all these silos that exist. So that was one thing that came out of that. And again, I think the whole issue was very well received. I was invited to be part of some work with CIHI, the Canadian Institute for Health Information, that looks at, they'd already done some work around developing indicators or listing some of the scope of practice for nurse practitioners. And they want us to now move forward to doing that with the other designations of nurses. So based on my report, they asked myself and CNA to work with them on doing so. So that was a great experience. And we'll see where this goes. I mean, the indicators are really based on the legislated scope of practice. So it's going to be very general. And they asked the regulators for the information, and I've put it together and so forth. So that's going to be released in June, they're hoping, pending any other crises that come up in between. And then also what I've done a lot of in the last probably 2 years as well is start to try to use my voice a bit through my role as one of the editors with the Canadian Journal of Nursing Leadership. So I was invited to be an editor back in 2019. So I was trying to find, again, ways to use that opportunity to use my voice, but also give others the chance to have a voice and write about what the work that they're doing. Because I think there's so much happening and there's so much great work that we're doing that we don't always hear about it because we don't have a platform to talk about it. So I was invited to be, or I suggested that maybe we focus one of our issues on mental health. And so they asked me to be the guest editor for this. So what I really focused the issue on was around not just describing mental health. I think, again, we've got lots of information about mental health of nurses, is how can we move forward and what are people doing? So we invited a lot of guest authors that were our either senior leaders or managers within different sectors. We tried, again, not to have it just on Ontario and not just on hospitals, but we invited from across the country and different sectors to talk about what have they been doing for nurses. And I wrote an editorial that talked about, the tsunami that we've been experiencing within mental health, and that again, it's not new. We've talked about burnout back in 2000. So that was a good opportunity to give voices to others. And then one of the last studies one of the more recent one I've been working on is another one very interesting that was funded by one of the special COVID grants through the CIHR that I'm working on with, I'm co-principal investigator with Wendy Gifford from the University of Ottawa, as well as Craig Phillips, who's also at the University of Ottawa, and then Wendy Muckle, who's the CEO of the Ottawa Inner City Health in Ottawa, which is one of the organizations that works with the homeless and street involved communities in downtown Ottawa. And this has been a very interesting study because it's, again, a context that I have I don't know anybody that's worked in this area, and it's not an area I understand. And it's not just focused on nursing, it's focused on all the frontline workers that are working with these communities. And they were already doing a fair bit of work around mental health support for them, but because of COVID and all the changes they had to make within their context, a lot of their resources, they couldn't move forward with them. And of course, it was much needed because not only is this the homeless population battling the COVID crisis, they're also battling the other pandemic, which is the opioid crisis. And they were, so a lot of their clients were experiencing friends dying on the street and being afraid of that happening to them. So we're just in the process of wrapping it up. And again, I think, the actual intervention is something that's going to be taken over by, it was already being done by a church group up in Ottawa, and they're going to continue doing the work. But what we want to do as well is also give this area an opportunity to have a voice. And we've had discussions about different publications, different ways of doing that, and they certainly have been very active themselves, talking about social justice and some of the areas. But it's just trying to find ways to work with them to see if we can help make it, describe it in different ways for them with some of the funding that we have. And the last piece I'm going to talk about, and I'm going to open up for discussion, is my latest article that I've just submitted for the Canadian Journal of Nursing Leadership is around respect. And one thing I've found when going through a lot of the reports, or even just looking at Twitter and all the media reports, is how all I hear over and over again is the lack of respect that nurses feel. And so conversation with Barb Milden, who is currently a chief executive officer at a community agency up in Lindsay. And Barb's been in very many different roles within nursing across the country. She's policy. She was president of CNA at one point. So very, very knowledgeable. And so we kind of had a discussion about ways to look at the reports that were done back in the early 2000s and see, what does respect mean to nurses, and why are we still in the same place? And this is sort of where I'm going with my recent thinking. So that's just under review. Hopefully it'll be published in the next couple of months. And I'm going to leave just with two quotes. So the first one, is we should never take nursing or nurses for granted. No good can come out of such thoughtlessness. And indeed, much damage already has been done by that attitude. And then the second quote is, whenever the end does come and the final wave crashes on the shore, it will carry with it a reckoning for the people who bore the heaviest burden of this pandemic. That's Canada's 440,000 nurses. And if we were in a room, I'd ask you, what was the date of each of these quotes? The first one is 2001, which I think is still very relevant today. And it was by Michael Decter and Mike Villeneuve in one of the papers I showed in my slides, talking about the consequence of the decade of healthcare cuts that we had experienced. And then the second one is by Elizabeth Renzetti, who's a columnist with the Globe and Mail, who back in mid 2021 had this quote, which I think is so true. So you can see 20 years apart, same old. So thank you very much for listening. I think it's 1:45, so I ended exactly when I wanted to. So I would like to open it up for chats. I'll stop sharing my screen so I can see people. And certainly welcome any comments, questions, feedback.
Joan, I'm just going to jump in and start off, everyone, and just say thank you so much. Not only is it an impressive expert presentation finishing exactly at 9:45, or sorry, 12:45, wrong time zone, But I just wanted to say thank you for your very thoughtful presentation. Like you've covered so much ground, thinking about changes to practice, thinking about changes like organizationally scope, education. It's quite impressive. I had one thought. I mean, I wrote down so many different things to myself, but I was really curious that you went into outside of health planning to think about informing the one study that you had sent out, looking at leading indicators. And I know you're doing some work looking at frameworks for planning, health human resource planning. Is there anything in other literature about resource planning, human resource planning, that you think might be informative of the healthcare system, like framework planning?
Off the top of my head, no. I can't say when I was looking through a lot of that literature that it necessarily was something I was looking at. From that frame, and certainly all of my, I'd say the majority of my research comes from practitioners. So I rely a lot on their experiences and what they're looking for, and I certainly bring in the evidence to support it. So the leading indicators came from actually someone I did my undergraduate with many years ago, and she runs her own occupational health and safety company up in Sault Ste. Marie, and she's been at me for years to do a research grant because she was doing her master's, and this is one area that was really passionate for her. So I think I can't. So the short answer, I guess, or the long answer, I guess, is no, I haven't.
Yeah, no, it's interesting though. I'll stop talking. I do have a whole bunch of other things I want to ask you about, but I'll open it up to many others here in the call.
Duncan?
Joan, it's Duncan. Do you have a counterpart who has done equivalently deep analysis of the provision of nursing and other health professionals in those European countries that you showed in an earlier slide have a much more dense relationship or population of nurses than we do? So we pay about the same overall cost of our so-called system as most European countries, ignoring the United States for the time being. I'd like to ignore them permanently, frankly. But are the problems that you have just gone through comparable in, say, Norway or Denmark or the Netherlands, who have a lot more nursing participation in their workforce than we appear to do?
I don't have an evidence-based answer for that, Duncan. I know there's certainly been books that have written about, like physicians and so forth, that, some of the countries have less turnover of their physicians. I mean, I do think some countries do it better. And you're right. I think like the Norway, like the main European countries, or maybe even Australia. But I think what COVID has shown is that some of the issues are still the same. Now, whether they're the same severity or not, I don't know. I'd have to ask. The International Council of Nurses would be the group that I would ask for information about that, because they'd be the ones, and they might have in their somewhere on their website the breakdown of some of their data.
Thank you.
Joan, I was going to pick up on, Don, I'll let you ask your question. I'll circle back to Duncan's comment.
Oh, I was going to start with Duncan's comments first. There's an interesting little thing you can get by putting two separate pieces of data together. So we have fewer nurses per capita than the average of the OECD countries. But if you take the number of nurses we have and you add the number of unfilled positions, we're right on the average. So it's interesting, the number of positions that are on the books of the various different institutions would take us up to the equivalent, but we persistently underfill them, all the more so during 2020 and 2021. But it was a big vacancy number going. Well, we've had a vacancy survey since 2011, and the vacancy for nurses has been very high since then. So it's kind of interesting, that distinction between the number of positions that are on paper vis-a-vis the perpetual underfilling of the ones that are on paper. My question was just on the governance structure of it. There's so many different problems and then so many different players. How does it all come together? Obviously, we need to produce more nurses in one way or another, but that's not going to solve the problem if the profession continues to be a revolving door. So you have to change the conditions as well. And that has many different pieces. And I don't think you mentioned it, but the one that's in the paper today is the wage restraint of the 1% increases. Typical economist, when you have a shortage of labor, you typically change the wage, and that one's off the table. Who brings that all together? Probably not nationally, but even provincially, no one's bringing it together now. Who would do that, and is that feasible?
Well, and that's a good question. I mean, there's a couple of comments too about numbers and data, and I think I know the government's been asking the Canadian Nurses Association for a while, like, how many nurses do we need? And I don't think I haven't seen anywhere where there's been a number given. There's certainly been lots of numbers about shortages. There's been a lot of numbers about this and that, but to actually say this is what we need. And I'm surprised. I thought there would be someone doing work on that would have jumped at that chance. And you're right, data is continual challenge. So it's because every day is a little different with how it's reported and what it's reporting on. So who's leading the charge? I think basically what you're asking, Dawn.
Yeah. Who would lead it? I assume nobody's leading it at the moment, but.
Well, nationally, it is the Canadian Nurses Association and the Canadian Federation of Nursing Union, which is our, the challenge with they're at the federal level. Within Ontario, we have our professional body, which is the Registered Nurses Association of Ontario, and the Ontario Nurses Union. So we have unions and professional bodies. Regulators don't tend to be leading it because they're not supposed to be advocating for nurses, right? They're there to they don't in my experience they don't tend to do they don't do this side of it. So it has been the professional associations and unions, which don't always agree and kind of do their own thing, which is that, wanting that more unified voice, but there's always a history with everything we do in nursing. So, but certainly at the federal level, CNA and the CFNU have worked really hard at creating a more unified voice, and they're at the federal government all the time. Like CNA goes through like 3 weeks where they'll be advocating every day with a member of parliament within the federal government. So they've been leading a call, but the challenge is financially they're struggling because membership is voluntary to CNA. And so if we as nurses who already have to belong to our union or belong to our regulator and pay X number of dollars, and then also depending where we work, are unionized, we don't always put money forward to see, our voluntarily based professional association.
So not to hog it, but just for 1 second, the nursing association is absolutely leading the charge in identifying the problems and in a sense lobbying for it, but they don't have the tools at their disposal to implement the change. They can't create the spots for nurses in the universities and the colleges. They can ask for them, but they don't implement that. They can't really change the working conditions. They can't point out what should be changed. They could advocate for what should change, but somebody else holds that. So I was sort of wondering on the other side of that. And it's also interesting, as I said, because they're national associations, their interlocutor is the federal government, but the federal government doesn't have much of a role in this space. And, it's the same thing with the doctors. You have the Canadian Medical Association, which is kind of an odd concept because their interlocutor is the federal government, which has a very limited role in health.
Yes, and not every professional association is part of the federal association. So and provincially, I mean, this is a whole different talk, but it's, like within each province, even the professional associations, like in Ontario, we have a very strong professional association that's been in place since the 1960s. But other provinces, because they used to be combined with the regulator, it used to be colleges, so that, it would be college and association, they're now being put into separate bodies because of either through voluntarily doing that or through government mandates, because they don't want advocacy and the public perspective to be together. So now, yes, they're in other provinces, but they don't have the power because they either are just starting or they also have struggling membership. So, but there's very strong unions in almost every province. So that tends to be, I think, why the focus is so much on hospital-based, because that tends to be where a lot of union members are. Not all of them, but a significant number.
Thanks for that, Joan. There's so many complexities to this, and I'm pulling up what Lee Chapman, I don't know, Lee, if you want to unmute yourself, or I'm happy to mention it in the chat. Lee asks, could regulators do more with respect to critical nursing shortage and the myriad of HHR challenges? And just even thinking across professions, the unified voice of nursing, let alone like all the professions, you know, to cohesively think about this. And I know we only have 4 minutes because we could probably be here for days.
And I think I think regulators are cautious, and I don't know. In my experience, when I used to attend the CNA board meetings, like they are very cautious about making sure they're not seen to be advocating for nurses. So I think some of them might move into there a little bit, but I think they do it cautiously and maybe not as strongly as we would like them to. Scope of practice is a factor to consider. Just reading it.
Yeah, I'm just thinking Dana has a great comment too about workforce retention and.
Yeah, and that to me is and that's my article on respect is focusing, like, you know, we need to also start increasing the numbers, but it starts with retaining the ones we have, right? And that's, you know, and that's what the data for the last 30 years has shown. We're not improving the working conditions enough to retain people.
I raised that, Joan, because way back in 1980, there was an article that came out in the American Journal of Nursing that showed that when Beth Israel in Boston gave nurses the autonomy to actually discharge patients, and they all had a salary of $60,000 back in 1980, their retention went down. I mean, they had no issues with work, with issues with retention. So I just wondered, and I don't know whether I have thought about it over the years, if I should go back and see if they're still doing that. I doubt it. I'm sure that somehow went by the wayside, but I found it very interesting then that by giving them more autonomy and a better pay, that it actually improved care, and it also led to better working conditions. Not sure if there's been any follow-up with that.
I think nurse leaders healthcare leaders are doing as much as they can, and I think it could be done better or differently. I think, you know, again, I think a lot of what we hear is that nurses feel they're not being heard, that they're not part of the decisions, and they're not part of change. And that's, again, that goes back to the respect and feeling valued. And I think if there's any way to do that differently than do for it, I mean, it's, you know, it's healthcare leaders are doing what they can, but and government, I find, I don't know, my experience, and this is again my opinion, I find the government right now is empathetic to people, but they're not listening, right? They're not hearing that this is. But I think people were very disappointed with the federal budget that there wasn't more in there around that. And you know, and you can't just say let's increase all the seats in all the education institutes. Well, sorry, I mean we burnout's also very apparent in here, and lack of resources, right? So you can only, you know, create problems in another area with, you know, that needs to be looked at better as well, and certainly putting the numbers in the seats within education isn't going to help if they quit within their first year.
Joan, I'm going to jump in here. It's 10 o'clock, or sorry, I'm still clearly I am not in Ontario. It's 1 o'clock here. And this is such a compelling discussion, and it really makes me think of so much interest here of doing it like a mini series on HHR. And I know Duncan and Dawn have lots that we could be talking about and systematically breaking down. Again, each one of these threads could be an hour discussion: scope of practice, education, organizational structure. So just wanted to thank you for really bringing all of this work together from a nursing perspective. It really is an impressive body of work. And thanks again to everyone for joining here today. This will be posted on YouTube, and I'm going to connect with you, Joan, and just think about like a plan for other conversations around these issues. Thanks, everybody. Have a great rest of the day.
Bye.